So thank you once again. So this talk is on peripheral retinal degenerations to treat or not. So a lot of patients come to your OPD with these peripheral lattices or breaks. So now this talk will dwell on whether to treat these patients or not. So why to treat these peripheral lesions is we have annual incidence of RD 10 to 18 in 100,000 people, and 20 to 40% of them have had cataract surgery when they present with this retinal detachment, and more half of that occurs in myopic eyes. So what is peripheral degeneration? It's a deterioration and loss of retinal tissue leading to thinning in the retinal periphery. And patients who undergo refractive surgery to reduce myopia should be informed that they remain at the risk of RD despite reduction of the refractive power. So those patients with peripheral degeneration who are undergoing LASIK and all should be informed that even after the LASIK, they remain at a risk for retinal detachment. So I won't go much into this. So there are classification based on the intraretinal, vitreoretinal and chorioretinal degenerations. So most commonly when you present to the OPD is your lattice degeneration. Incidence is 6 to 8%, 30 to 40 in myopes, and 30% RD associated with these lattice degenerations. So let's look at this case. So this was a patient who came with a lattice degeneration to our OPD. So he was asked close follow-up and observation, but then he came after 2 years with a subtotal retinal detachment, what you see over here, and then the lattice has given way, and this is post-treatment after vitrectomy, the retina is attached. So see, now this other eye is at risk to develop a retinal detachment. So he had a lattice with hole in the other eye, and that has been nicely barraged over there. So you can see the type of laser which we have done, close knit laser, all the spots are coalesced together. So that kind of laser you need to do for these retinal degenerations. So that's a close-up view of the laser which we have done in the periphery. So you can either do with your contact lens or you can do with your laser indirect ophthalmoscopy. So snail track degenerations are also there. So prevalence is 10% and myopes are more frequently affected. So shape, size and orientation will be similar to a lattice, but it will appear, little more longer. So this is one example of a snail track degeneration with holes. So this patient asymptomatic, he came for a routine exam and we found this snail track with huge retinal holes in the periphery there. So this you cannot leave, you have to laser it, and this is post-treatment with the laser. You can see how close, it's not like a PRP laser, how close those burn marks are together, almost confluent with each other, and you have to laser and connect up till the ora serrata. So you need your indirect laser to do this kind of a laser barrage in the periphery. So next are these, some of them atrophic holes. So they are not associated with vitreoretinal traction, but they can be present with lattice. Now it is always questionable whether to observe these patients or whether to laser them, but atrophic holes can be observed and closely followed up. But if the patient cannot follow up, then you can might as well give them an option of lasering these holes. So next, snowflake degeneration also can present, no requirement for laser here, and white without pressure also as the peripheral retinal degeneration. Here again there is no requirement for laser, but however white without pressure can predispose to giant retinal tears, and such patients also needs to be closely followed up and observed. So what causes an RD in an eye with a peripheral retinal degeneration? It's mostly because of the PVD which occurs. So when the vitreous is detached from the retina, it tears one part of the retina away, leading to a horseshoe tear, and then that horseshoe tear causes that is an opening for fluid to go in and cause a retinal detachment. So there are two types. One is an acute symptomatic PVD, and sometimes they can be asymptomatic too. So when you have an acute symptomatic PVD, then you will have flashes and floaters when you have a symptomatic PVD, and that can cause, vitreous hemorrhage can be a presenting thing, even retinal tears as well as an RD can happen. So they need a repeat retinal exam after 4 to 6 weeks. Once you have the when a patient presents to you with PVD, you need to keep calling them up frequently as the PVD may keep progressing. So slowly it will detach from the posterior, then go up till the periphery. So these are the horseshoe tears, which are flap tears. They have traction. So they are high. When you see them, you should always laser them, and they are high risk for developing retinal detachment. So let's look at this case. He came with a vitreous hemorrhage. He came with complaints of floaters. So he had a PVD with a mild vitreous hemorrhage, but when you look in the periphery, you see there is a horseshoe tear, which is the source of the blood. The blood has trickled from the periphery and come to the posterior part, and then the horseshoe tear has been lasered and connected all around up till the ora serrata there. And this is 4 months after follow-up. You can see the tear has been nicely lasered, but however some vitreous condensation is still there. So he's not complaining of floaters, but he's still on follow-up. So the degenerations which dispose to an RD is important. Lattice, snail track, retinoschisis, white without pressure, holes and tears, and which don't predispose to RD also you should know. Snowflake, paving stone, honeycomb, white with pressure, meridional folds. So there are some AO treatment management options, but then it's all related to the Western population. So we need a uniform guideline. So in India, there is no uniform guidelines to treat these peripheral degenerations. So there are no clear recommendations. So there are different opinions, which creates doubts and confusion. Like, I would laser, I would not leave it. I would not laser. And due to the medical legal issues also, we tend to sometimes overtreat these patients. So suggested approach is step 1, what is the lesion? What are the vitreous changes surrounding the lesion? And you should also look at the risk factors. What are the risk factors in that patient which can predispose to a development of a retinal detachment? So here few of the recommendations are all symptomatic and asymptomatic horseshoe tears, operculated holes, lattice with retinal holes, atrophic holes should be treated promptly. So these are the Indian guidelines. All symptomatic lattice degeneration without retinal holes and atrophic holes, treatment is usually recommended. You can advise the treatment to the patient or you can tell them to closely follow up. And all asymptomatic lattice and all, they can be observed. And eyes with atrophic holes or lattice with where the fellow eye has already developed an RD or where there is a family history of a retinal detachment, they have to be treated. So they can be considered for treatment. So always family history, ask one-eyed status, fellow eye having a retinal detachment, all this you need to consider before treating these peripheral degenerations. And patients undergoing refractive surgery, you need to look for thorough examination to look for these lesions. And prophylactic barrage laser to degeneration should be done 2 weeks, at least 2 weeks before planning the LASIK or refractive surgery. And then retinal examination should be done at regular intervals for development or progression of the PVD, tears, and these macular other pathologies. So thank you.
Thank you, Shishir, for that wonderful presentation. If anybody has any questions for Dr. Shishir?
Please.
Hi, sir. Nice talk it was.
Thank you.
Sir, for pre-LASIK, if it is there is a lattice without a hole also, will you suggest a laser?
So again, there is a confusion over there. Usually what happens, these LASIK patients is they don't tend to follow up after treatment. So in them, you need to advise that you have to better to undergo a barrage laser. That is one concern. The second concern is that some surgeons think there is a theoretical risk of retinal detachment when you put that suction ring over the LASIK and that causes an increase in the pressure. So that doesn't really cause a RD, but there is a theoretical risk that can happen. So that's the reason why you laser these lattices before the LASIK. But if it was me, my opinion, I would definitely laser. And 3 weeks after the barrage laser, they can do undergo the LASIK procedure.
Yes, thanks.
Yeah. Any other thing? Okay. Thank you.